I mean, the pilots were designed to take a year. They took slightly longer because of the learnings. But here we are on the other side, very proud to say that we actually scaled up to all 47 counties, having piloted only in form. We took the critical learnings about financing, about quality, about service delivery, and scale those up. We did put a lot of effort before scaling up in terms of preparing the system, trying to figure out those supply chain mechanisms, trying to streamline those, trying to beef up the human resources for health because free at the point of care services means, more people show up, and the already stretched health workforce would needed to be augmented. We did quite a lot of work with the NHIF on our hospital insurance fund. We actually amended the act. We repealed it. It's now called a health insurance fund, a very important difference because now it can be used to pay for preventative care, where before it couldn't. We've also legislated that contributions now need to be mandatory, and we're working on the regulations to make that effective. Again, very important to take care of issues of adverse selection, take care of issues of moral hazard, take care of issues of supply-induced demand, and all the other kind of problems that come with private insurance, and really make sure that this public insurer is doing exactly what it needs to do, which is take care of the population at their most critical point. So we're really, really excited about the reforms at the NHIF, really excited at the scale up. What we did scale up with the intention of fully going to universal coverage through NHIF is we identified across the 47 counties 1 million households. That roughly comes to about 4 million people who have a full government subsidy. That's $60 a year, full government subsidy for the NHIF. And that started last financial year. It's carrying on. There will be an increment of 200,000 households per year until we've managed to cover all the indigents. This is running in parallel with the mandatory contributions for those who can pay. And now we have a new administration who are equally excited at the potential of NHIF. And there's already a lot of modeling happening around how exactly can we make those who can pay be able to come in and pay. And at the same time, they're also working on reforms of primary care. As I said, the fundamental revision of the NHIF Act means that it can now pay for preventive care, promotive care, which wasn't possible before. This will take care of that primary healthcare angle and make sure that we are not waiting until diseases are advanced to pay for them then, but we can take care of it for prevention. So really exciting times. The ground is set. It's that big catapult. It does require quite a bit of a budget. It does require a little bit of panel beating here and there. But, we are at the finishing line.